Muscles, tendons, and fascia. Carpal tunnel syndrome, anatomy. Median nerve is compressed as it passes through the carpal tunnel in front of the wrist. Boundaries of the tunnel, posteriorly, carpal bones, anteriorly, flexor retinaculum. Contents, median nerve, 8 tendons of flexor digitorum superficialis and profundus within ulnar bursa, flexor pollicis longus tendon within the radial bursa. After passing deep to the retinaculum into the hand, it gives motor supply to the 3 muscles of the thenar eminence and lateral 2 lumbricals, sensory supply to the lateral 3½ fingers. Palmar branch of the median nerve arises above the wrist, superficial to the flexor retinaculum. Carpal tunnel syndrome, incidence, the commonest type of the nerve compression syndromes. Etiology, conditions which increase tension under the retinaculum as pregnancy, myxedema, acromegaly, rheumatoid arthritis involving synovial sheath of flexor tendons, and may be idiopathic. Clinical picture, type of the patient, mainly middle-aged females. Symptoms, early, pain in the thumb and the lateral 3 fingers, gets worse by night, increases by fully flexing the wrist, relieved by injecting the tunnel with lidocaine and corticosteroids, plus splinting the wrist at night. The little finger is never affected in this syndrome. Palmar branch of the median nerve escapes the compression, and that's why the palm is not affected, because it passes superficial to the retinaculum, as we have previously mentioned. Late, paresthesia and altered sensation of the skin supplied by the median nerve. Weakness and atrophy of thenar eminence muscles. Signs, special tests, Fallon's test and Tennell's percussion test. Tennell percussion's test, percussion of the carpal tunnel, leading to tingling along the distribution of the median nerve. Fallon's test, flexion of the wrist for 1 minute, pain along median nerve distribution. Nerve conduction study, delayed conduction of the median nerve. Treatment in early cases, steroid injection to relieve the pain. Surgical division of the flexor retinaculum leads to pleasant results. The operation can be performed by endoscopy. Dupuytren contracture, also known as palmar fasciitis, incidence, males are affected 10 times more than the females. Etiology, idiopathic, some cases are familial, more in cirrhotics, alcoholics, epileptics, under phenytoin treatment, and diabetics. Clinical picture, affecting primarily the medial side of the palmar aponeurosis. The disease is bilateral in half of the cases, starting as a nodule at the base of the ring or little finger, followed by thickening and contracture. It throws the finger or fingers into flexion. The skin gets adherent to the fascia and contracts as well. The other fingers progressively become involved. Late cases involve the capsules of the metacarpophalangeal and PIP joints, leading to their flexion. The DIP distal interphalangeal joints are free. Palpation of the palm, firm, irregular shaped nodule, 1 to 2 cm proximal to the base of the ring finger. The flexion deformity is not lessened by flexing the wrist joint, opposite to the Volkmann's ischemic contractures. Treatment, early cases, physiotherapy, late cases, surgery, varying from minor subcutaneous fasciotomy, extensive operation leading to excision of the aponeurosis, joint capsulotomy, and skin grafting to cover the resulting defect. Volkmann's ischemic contracture, definition, fibrosis and shortening of the muscle of the front of the forearm due to acute ischemia and infarction. Acute muscle ischemia leads to infarction after 6 to 12 hours. Muscle fibrosis and shortening develop within a few months. Etiology, injuries around the elbow leads to brachial artery injury, leading to acute ischemia of the muscles of the front of the forearm, as in supracondylar fracture in children. Ischemia is more commonly caused by a tight plaster rather than due to the fracture itself. Direct brachial artery injury and arterial embolism. Clinical picture, early and established contractures. Early, while the arm is immobilized for fracture treatment, pain in the forearm muscles and hand. Passive extension of the fingers is painful and limited. Fingers and hand are pale, cold, and showing sluggish capillary circulation. The radial pulse may be absent. If the median nerve is ischemic, paresthesia or severe burning in its distribution occurs. Established contracture, pain is lessened by typical deformity appears. The forearm and the head appear wasted. All the finger joints are flexed, such as claw hand. Extension of the fingers is limited, but improves as the wrist is flexed, and this is to compare it with the Dupuytren contracture. Differential diagnosis of the claw hand, Volkmann's ischemic contracture, combined median and ulnar nerve injuries, lesions affecting lower roots or medial cord of the brachial plexus, such as clumps, paralysis, and malignant infiltration of the brachial plexus, advanced rheumatoid arthritis, spinal cord lesions as syringomyelia and poliomyelitis. Treatment for early cases, physiotherapy by gradual stretching and splinting. Late cases, the following procedures may be tried, such as muscle slide operation. The common flexor origin is detached from the medial epicondyle and fixed at a lower level. Tendon lengthening and tendon transfer. Appearance of early features in a patient with a fracture or after plaster cast application is very serious because at this stage the ischemia can be corrected and the muscles can be saved. Hand grip is weak, all the muscles have the same function, whereas when a claw hand is due to nerve lesion, some muscles will be completely paralyzed. Prevention: prompt restoration of the muscle blood supply before development of the infarction by reduction of the fractures and dislocations, releasing of the tight plaster cast, removal of constrictions. If the radial pulse doesn't return, explore the brachial artery and injured segment is excised and reconstructed by a vein graft. Chronic tendonitis, tennis elbow. Symptoms: pain in the elbow at rest and worsens when he uses his hand. Signs: attachment of extensor muscles of the forearm to the lateral epicondyle is tender. Etiology: direct trauma or repeated athletic activity. Treatment: by rest, and in resistant cases, local injection of corticosteroids and local anesthetics. Rotator cuff muscles or supraspinatus tendonitis incidence: the commonest cause of shoulder pain with movement limitation. Any of the rotator cuff muscles may be involved. The commonest is the supraspinatus tendon. Etiology: repeated trauma from sports or occupational activities. Inflammation often extends to affect the subacromial bursa. Symptoms: painful active abduction, particularly when the shoulder moves between the 60 and 120 degrees due to compression of inflamed rotator cuff and bursa beneath the acromion. It's known as painful arc syndrome. Treatment: conservative, using NSAIDs and immobilization followed by gradual active exercise to restore the full range of shoulder movement. Resistant cases, local injection of corticosteroid lidocaine mixture. Stenizing tenovaginitis causes fibrous stricture in a tendon sheath. Examples: trigger finger pathogenesis, thickening of fibrous flexor sheath at the level of metacarpophalangeal joint, leading to pain on tendon movement and local tenderness. Clinical picture: symptoms: when the finger is flexed, swelling of the tendon proximal to the constriction, leading to interference with the finger. Attempts to extend the finger may require passive assistance. Tendon snaps through the narrow area, likened to the snap of the trigger of a pistol. Therefore, it's called trigger finger. Signs: thickening of tendon or tendon sheath at the level of the head of the metacarpal bone. Treatment: early cases, splinting and steroid injection. Late cases, division of the constricting fibrous flexor sheath. Decurvence synovitis, inflammation of the abductor pollicis longus and extensor pollicis brevis tendon sheath at the point that they cross the wrist, leading to pain and limitation of movement. Active and passive movements of the thumb exaggerate the pain. Treatment: such as trigger finger. For the early cases, splinting and steroid injection, and for late cases, division of the constricting fibrous flexor sheath. Chronic bursitis, definition of the bursa: fluid-filled cavities lined with flattened epithelium similar to the synovium. Types: we have anatomical and adventitial. Anatomical bursae function to allow easy movement between the tendons, bones, and skin. Etiology of chronic inflammation, repeated friction. Clinical picture: mild pain, cystic swellings. Crepitus may be noticed if the bursa lining is rough or if the fluid contains small loose fibrinous particles. Common sites: prepatellar bursitis, called housemaid's knee, site over the lower half of the patella behind the skin. Infrapatellar bursitis, clergy's man knee, and the site is between the ligamentum patella and the head of the tibia. When ligamentum patella is distended, a fluctuating swelling appears on either side of the ligamentum. Olecranian bursitis, student's elbow, between the skin and olecranium. Semimembranous bursa, site between the semimembranous tendon and posterior aspect of the medial femoral condyle. Type of the patient: middle-aged adult. Symptoms: swelling behind the knee joint. Examination: cystic swelling on medial side of the popliteal fossa, just above the joint. Contraction of semimembranous muscle during knee flexion. The swelling diminish in size. Differential diagnosis: Baker's cyst. Baker's cyst definition: a pulsion diverticulum of the knee joint. Types of the patients: with rheumatoid arthritis or osteoarthrosis, or in elderly patients. Clinical picture: presenting as cystic swelling below the level of the knee joint and deep to gastrocnemius muscle. reduce into the joint. This is a characteristic finding. Adventitious bursae, site in any site of fraction between two layers of tissue. Example, the bunion, the volus between skin and head of the first metatarsal, particularly with the helix valgus deformity. Treatment: if fraction can be abolished, bursitis may regress, and if can't, excision and correction of any underlying deformity. Soft tissue sarcomas. Definition: malignant tumors arising from the extraskeletal connective tissue. Incidence: 1% of all malignant tumors. Uncommon. Etiology: the exact etiology is unknown, but some disorders are associated with certain types of soft tissue sarcomas, such as lymphangiosarcoma in the chronic post-mastectomy arm edema, neurofibrosarcoma with von Recklinghausen's disease. Pathology: site, extremities and pelvic girdle in majority, trunk and retroperitoneal tissues. Types and histological picture. Origin: primitive multipotential mesenchymal connective tissue cells which differentiate during neoplastic transformation, leading to liposarcoma, angiosarcoma, malignant fibrous histiocytoma, malignant nerve sheath tumor, fibrosarcoma, leiomyosarcoma, rhabdomyosarcoma, synovial sarcoma. Gross appearance: cut section is fleshy, showing areas of necrosis and hemorrhage. Characteristic feature is the presence of well-defined false capsule, but the capsule is a part of the tumor and infiltrated with malignant cells, which spread beyond it, leading to obsolete inoculation. Grade of malignancy: histological grading and DNA ploidy. Histological grading: more influence on prognosis than the type of the tumor, assessed according to certain histological criteria, which include extent of mitosis, extent of necrosis, pleomorphism, cellular anaplasia. The tumor is then judged to be low, intermediate, or high grade. Spread: local within the musculofacial compartment in which it arises. Facial septa resist spread temporarily, then extracompartmental spread occurs. Bloodborne spread mainly to the lungs. Lymphatic spread is unusual. DNA ploidy: it's used to grade these tumors. A normal cell is euploid, containing 46 chromosomes, 2n. Malignant cells are usually polyploid, containing 4n, 8n or more, and aneuploid, bivar chromosomal content. Deviation of tumor from normal ploidy can be assessed using flow cytometer, determining the tumor aggressiveness. Clinical picture: type of the patient in all age groups, including children, the commonest in 5th and 6th decades of life. Symptoms: painless swelling which has been gradually enlarging over several months without disability, therefore delayed presentation. Signs: soft or firm inconsistency depending on the amount of deposited collagen. Investigations: imaging, CT and MRI are the investigations of choice, showing the tumor extent and its relationship to the muscle groups. Chest X-ray and CT scan detect pulmonary metastasis. Tissue diagnosis aim to obtain histological confirmation of the diagnosis before planning treatment. Methods: open biopsy and true cut needle biopsy. True cut needle biopsy is under local anesthesia, and open biopsy, when cannot reach, diagnosis after needle biopsy. Treatment: operable cases. The standard is combination of radical surgery excision with adequate safety margin. If radical resection will leave a useless limb, amputation is followed. Adjuvant radiotherapy in inoperable cases, as patients with pulmonary metastasis or huge retroperitoneal sarcomas which are adherent to important irremovable structures considered to be beyond cure. Differential diagnosis: benign soft tissue tumors such as lipoma, deeply seated hematoma, malignant lymph nodes, bone tumors, tumor-like conditions of soft tissues such as fibromatosis. Best example: desmoid tumor, Paget's recurrent desmoid tumor. Site: in the rectus sheath and external oblique aponeurosis. Type of the patient: middle-aged women. Growth rate: very slow. Treatment: wide surgical excision, as a low-grade soft tissue sarcoma has tendency for recurrence after an apparently adequate excision. Nodular and proliferative fasciitis, and finally proliferative myositis and myositis ossificans. The hand and foot tendons: cross the wrist, whether ventrally, flexors or dorsally, extensors. Function: to move the wrist and fingers. The long flexor tendons arise from two muscles, the flexor digitorum superficialis sublimis and the flexor digitorum profundus. The flexor digitorum superficialis, each superficialis tendon splits opposite medial phalanx, forming a talon, and inserts at sides of the anterior surface of this phalanx. The flexor digitorum profundus, the tendon passes through the superficialis tunnel and crosses the distal interpharyngeal joint to be inserted in the front of the base of the distal phalanx. Superficial muscle doesn't flex distal interphalangeal joints, while the profundus can move all joints which it crosses. Synovial sheath function, allowing free frictionless movement of the hand. The flexor and extensor tendons are enclosed in 2 layers of synovium, separated by fluid. Opposite each finger, the flexor tendons are enclosed in a digital synovial sheath that's covered by fibrous flexor sheath. The radial bursa encloses flexor pollicis longus. The ulnar bursa encloses superficial and deep flexor tendons of other fingers in palm and distal forearm. Tendon sheath infections spread due to radial and ulnar bursae commonly communicate, and ulnar bursae communicates with little finger synovial sheath. Intrinsic muscles, the thenar and hypothenar muscles, flexion, abduction, and opposition of the limb of the thumb and little finger respectively. The thumb has an additional adductor pulsus longus. It's adductor pulsus muscles without the longus. The interossei, the dorsal abduct, while the palmar adduct. They control the metacarpophalangeal joints. The lumbricals arise from the flexor digitorum profundus tendons, inserted with long extensor tendons in the extensor expansion. The lumbricals and interossei place the hand in writing position, which is a flexion of the metacarpophalangeal and extension of the interphalangeal joints. The thumb has no lumbricals. Bones. Carpus is formed of 8 small bones arranged in 2 rows. Metacarpus, 5 metacarpal bones which articulate with the phalanges at metacarpophalangeal joints. The phalanges, the thumb is formed of 2, while each of the other 4 fingers are formed of 3. Flexor retinaculum extends transversely across the interior concavity of the carpus, converting it into a tunnel. Structures passing through the carpal tunnel to reach the hand, the long flexor tendons with their synovial covering, and the median nerve. Nerves. Median nerve, ulnar nerve, and radial nerve. Median nerve, motor supply, thenar muscles except the adductor pulsus, the first lumbrical. Sensory supply to the lateral 2/3 of the palm skin and the interior surface of the lateral 3½ fingers. The ulnar nerve, main motor supply of the hand muscles, motor supply, the rest of intrinsic muscles, sensory supply to front and back of the medial third of the hand and medial 1½ fingers. The radial nerve, no motor branches in the hand, sensory supply, the rest of the skin of the dorsum of the hand fingers. Facial spaces, mid-palmar space, boundaries, anterior, the flexor tendons of the little, ring, and middle fingers. Posteriorly, the fascia covering the interosseous muscles. Medially, fibrous septum separating it from hypothenar eminence. Laterally, strong fibrous septum extending from the palmar fascia to the middle metacarpal bone, separating it from the thenar space. Arteries, the radial and ulnar arteries communicate through the superficial and deep palmar arches. Branches, digital branches which run on each side of the fingers in a dorsal position to the corresponding digital nerves. Because of the free communication between them, ligation or block of one of them doesn't affect the viability of the hand. Skin, the palmar skin, devoid of hair and sebaceous glands, tough and adherent to underlying palmar aponeurosis. The dorsal skin, soft and rests on loose areolar tissue. Because of this difference, edemal fluid collects on the dorsum. Hand infections. Etiology, the causative organism, Staphylococcus aureus in 90% of cases, route of infection through minor injuries and punctures of the hand. Clinical picture, type of the patient, prevalent in manual workers and housewives, symptoms, pain, swelling, and fever. Examination, site of infection is known by finding the point of maximum tenderness rather than the area of edema. Investigations, plain X-ray. If a foreign body is suspected, blood sugar with those recurrent infections may reveal diabetes mellitus. Treatment, antibiotic administration immediately started. The chosen drug against Staph aureus is fluxacillin, erythromycin, amoxicillin, clavulanic acid combination, and first or second generation cephalosporins. Hand elevation to reduce the pain and edema. Surgical drainage, indication, evident pus formation from the start, and no response to 1-day intensive antibiotic therapy. Method, general anesthesia except in paronychia and distal pulp space infection. Local ring anesthesia without adrenaline at finger root. Apply a pneumatic tourniquet around the upper arm after hand elevation for a few minutes to obtain clear bloodless field. Appropriate skin incisions and pus is drained by sinus forceps. Pus is sampled for culture and sensitivity. Soft rubber drains are preferred, such as piece of surgical glove. Post-operative elevation, physiotherapy, and wound dressings. Classifications, we have cutaneous and subcutaneous, paronychia, subcuticulous, and subcutaneous whitlow, pulp space infection, whip space infection, facial spaces, mid-palmar space infection, thenar space infection, hypothenar space infection, and space of Paruna infection, synovial sheath, acute digital tenosynoviitis, ulnar bursitis, and radial bursitis, and finally, bones and joints. Paronychia, acute paronychia, definition, acute suppurative infection of the nail fold, incidence, the commonest form of hand infections, treatment, pus drainage, used a fine-tipped scalpel to raise the nail fold and to incise the skin cap through which the pus points. If there is a sublingual extension, excise the related part of the nail. Chronic paronychia, type of the patient, chronically wet nails as dishwashers, associated fungal infection and nail deformities are common. Treatment, keep the hands dry, antifungal therapy, and removal of the nail in resistant cases. Subcuticular and subcutaneous whitlow or abscess, subcuticular whitlow, a subepithelial collection of pus, drainage by excision of the insensitive roof without anesthesia. A subcutaneous abscess requires anesthesia for drainage. Kullerstad abscess, abscess has two communicating components, subcutaneous and subcuticular. Pulp space infection or felon. The commonly infected is distal pulp space. Anatomy, site anterior to the distal phalanx. Content, we have fatty tissue which is divided into locules by multiple septa running from skin to the front of the bone. Proximal boundary, insertion of profundus tendon to distal phalanx. The digital artery divides in the middle segment of the finger into epiphyseal branch and diaphyseal branch. Epiphyseal branch entering the articular end outside the pulp, where the diaphyseal branch traverses the pulp. Clinical features and complications, edema, high rise of tissue pressure as it's a tight compartment leading to severe pain. If neglected, septic thrombophlebitis of the digital vessels leading to osteomyelitis of the shaft of the terminal phalanx. Luckily, regeneration can be obtained from undamaged proximal part, which is supplied by the epiphyseal branch. Treatment, early surgical drainage, incision is over the most tender point. Don't wait for fluctuation in pulp space infection. Mid-palmar space infection, site, deep to the tough palmar aponeurosis. Etiology, punctures, spread of whip space or tendon sheath infection. Clinical picture, marked dorsal edema. Treatment, pus evacuation through incision in one of the transverse palmar creases. To avoid injury of deep important structures, the incision is made through the skin only, and then a sinus forceps is pushed inwards and gently opened to let pus out, and this is called Helton's method. Whip space infection, clinical picture, swelling leading to separation of two adjacent fingers. The complications are spread to the lumbricals or mid-palmar space. Treatment, pus evacuation through dorsal longitudinal incision between the fingers. Thenar and hypothenar spaces infection, clinical picture, ballooning of thenar eminence and edema of the hand dorsum. Treatment, drainage through incision at the site of maximum tenderness or where the pus points at the skin. Incision is done along the medial side of the thenar eminence and should stop 2 cm distal to the distal wrist crease to avoid injury of the branch of the median nerve that supplies the thenar muscle. Infection of the space of Paruna, site, distal part of forearm between pronator quadratus and flexor muscles. Treatment, drainage along the ulnar side of the forearm. Acute tenosynoviitis, this is the most serious condition of hand infections. Etiology, sequel of deep pen pricks. Clinical picture, symptoms, pain and swelling of the finger due to involvement of a digital flexor sheath. The patient keeps it in the semi-flexed position. Signs, active or passive movement, stretches the inflamed synovium leading to severe pain. Tenderness is maximum just proximal to the crease over the metacarpopharyngeal joints, which is synovial sac proximal extent. Little finger sheath affection, spread to ulnar bursa, marked hand swelling, semi-flexion and limitation of movement of the medial forefingers. Diffuse palm tenderness that may extend to the distal part of the forearm, leading to maximum point of tenderness may be on the ulnar side of the palm between two palmar creases, and this is called Cannaville's sign. Radial bursitis produces a similar picture in the sum. Complications, thrombophlebitis of the tendon vessels leading to sloughing and stiff useless finger. Infection spread to the mid-palmar space and the space of Paruna. Treatment, conservative and surgical drainage. Surgical drainage indications, lack of response to intensive conservative treatment. Incision, inflamed synovial sheath is drained through 2 incisions, one at the proximal and another at the distal end. Fine catheter is inserted through each incision, allowing drainage. Irrigation of the sheath with antibiotic solution. Ingrown toe-nail definition. A sharp edge of the big toe nail impinges on the adjacent skin fold. Incidence, common problems especially in young males, predisposing factor, faulty nail trimming, oblique nail sides, leading to a sharp spike, or wearing tight shoes, leading to pushing this spike in the soft tissues. Complications, infection, may be made worse by a tendency of the patient to cut the nail. Treatment, conservative treatment, indications, early cases. The aim, to lift off the nail spike. Method, a band of gauze soaked in antiseptic inserted beneath the ingrowing part of the nail to raise it up and alleviate the injured tissues. Thinning of nail center, making it flexible and facilitates the edge elevation. The bandage is changed daily until the nail grows past a nail fold. The patient is instructed to avoid tight shoes and shown the proper method of square nail trimming. The center of the nail is kept at the same level of its edges. The surgery, indications, failure of conservative treatment and for suppurative cases. Methods, done under general or local anesthesia. Tourniquet is desirable to provide a clear bloodless field. The side of the nail is then embedded. The side of the nail which is embedded is excised together with the infected skin and granulation tissue. The tough, white germinal matrix is excised back to its origin, just distal to the interpharyngeal joint. Phenol application to ensure complete ablation of the germinal matrix. If the area is heavily infected, the wound is left open to granulate, otherwise its edges are loosely approximated. In severe suppurative infection, simple nail avulsion, leading to rapid relief, but recurrence is common with nail regrowth, so wedge segmental excision of the germinal matrix is a definitive treatment. The nail grows from the germinal matrix that shows as a white crescent, this is called the lanula. Under its proximal part, removal of the lateral and medial part of the germinal matrix prevents the regrowth of the corresponding part of the nail. Swellings of the hand, incidence, great majority, 94% are benign. Simple ganglion, definition, small cyst containing clear gelatinous fluid, pathogenesis, protrusion of a joint or tendon synovial membrane, becomes isolated, forming a cyst full of synovial fluid. The fluid thickens to form the characteristic jelly-like ganglion content. Synovial membrane protrusion may be acute or chronic. Site, most commonly found on the dorsum of the wrist. Clinical features, symptoms, painless, small rounded cystic swelling, usually on the dorsum of the wrist, less commonly on the dorsum of the foot. Signs, tense cystic, giving false impression of being hard. Characteristic sign is that the mobility of the swelling is markedly restricted by stretching or by contraction of the related tendons. Treatment not indicated unless the patient insists. Aspiration or rupture of the cyst by applying direct pressure. Temporary disappearance followed by recurrence. Excision, the only definitive treatment, done under general anesthesia and a tourniquet is applied. The wall should be excised completely, otherwise recurrence occurs. Glomus, tumor, incidence, rare tumor, origin, heat-regulating arteriovenous shunts, the unmyelinated nerves that controls them, site, anywhere in the skin but commonly found beneath a nail. Clinical picture, markedly painful and tender, has red or bluish color, differential diagnosis, subangular hematoma, exostosis, and melanoma. Treatment, total excision under magnification, implantation dermoid cyst, etiology, puncture wounds, drive in small pieces of skin in the subdermal tissues, skin produces sebaceous material, forming a cyst, site in the distal phalanx. Hand injuries, classification, tidy, clean-cut injuries, caused by sharp objects as knives and broken glass, skin is cleanly cut and tendons, nerves, and vessels are affected. Untidy or crush injuries cause crushing forces and by burns, tissue devitalization, all hand tissues are affected, including the bones. Emergency, treatment of the multiple injury patients, the ABCD. An amputated hand or digit is kept in a clean polythene bag, which is placed in a container full of cold water at 4 degrees Celsius. It shouldn't be frozen. Then urgently refer the patient to a center that is equipped with microsurgery facilities. Prophylactic antibiotics and tetanus prophylaxis are administered. Assessment of injury, clinical and radiological assessment should include the skin, nerves, arteries, tendons, and skeleton. Inspect the wound and examine the hand for deformities, sensory and motor deficits. In many cases, pain limits the value of these tests and final diagnosis of the extent of the injury is obtained during surgical exploration. Treatment of minor injuries, subangular hematoma definition, painful condition due to blood accumulation beneath the nail. Treatment, evacuation of the accumulating blood by drilling a hole in the nail using the needle of the syringe. The procedure is painless and requires no anesthesia. A minor skin wound, stitched under local anesthesia. Principles of surgery for hand injuries, anesthesia, general, preferred, local intravenous anesthesia with a tourniquet, or nerve blocks with local anesthetics. Indications for injuries of the distal parts of the fingers. The brachial plexus, median or ulnar nerve may be blocked according to the site of injury. The digital arteries are end arteries, and if they are thrown into prolonged spasm by addition of adrenaline to the digital block, it leads to gangrene of the finger. A tourniquet, clear bloodless fluid, it should be released within 1 hour. The use of magnifying loupes or microscope is desirable. Careful wound toilet using saline irrigation removes foreign body and debris. Excision of devitalized tissues in untidy injuries. Hemostasis by ligation of the small bleeding vessels. An injured radial or ulnar artery can be ligated without affecting hand viability. If facilities and experience are available, repair of an injured artery is a better alternative. Arterial repair is a necessity if both main arteries are injured. Nerves, according to the presence of necrotic tissue. In tidy wounds, primary repair of cut nerves. For untidy injuries or contaminated wounds, postpone the repair after wound healing and resolution of the inflammation. Tendons as nerve repair, suturing with non-absorbable non-irritant material as polypropylene. Success of tendon repair is endangered by the development of adhesions which limit its mobility. Tendon grafting is reserved for complicated cases with loss of substance and for recurrent cases. Bones and joints should be managed either operatively by fixation internal or external or non-operatively by a cast or splint. Joint dislocations should be reduced. Fingertip injuries with skin loss. In skin loss only, cover the fingertip by split or full thickness graft. With fingertip amputations that expose the bone, skin grafts will not take. And local skin flaps are used to cover the defect as cross-finger flap or advancement of 2 lateral triangles of skin and subcutaneous tissue. Skin closure done without tension. Contaminated wounds are left opened. Wounds of human and animal bites are highly contaminated with a mixture of bacteria, including anaerobes, and should never be sutured. Microsurgical reimplantation of severed parts gives good results when it's done early for clean-cut amputation, useless if the part is severely crushed. Tendon adhesion is most marked in flexor tendon injuries in the area between the distal palmar crease and the middle of the fingers, where the flexor digitorum superficialis and profundus tendons are enclosed with the digital fibrous flexor sheath. With improvement of surgical techniques, the tendency is now for direct suturing irrespective of the site of injury. Post-operative care, the hand is bandaged in the position of function, the metacarpophalangeal joints are flexed, while the interphalangeal joints are extended, the wrist is slightly extended, hand is kept elevated for a few days, minimize edema formation. Physiotherapy started as early as possible to allow restoration of the hand function. And this concludes muscles, tendons, fascia, hand and foot.